All right, so next I want to talk about our first article, which was by Matsuzaki et al. And in this article, they are looking at depression um, and rehabilitation, and they're contributing something that I think is a helpful distinction. So in it, they talk about the distinction between depression and apathy. Now, apathy is defined as the absence or lack of feeling, emotion, interest, or concern. And depression is dysphoric mood or lack of motivation, um, along with, the associated behavioral, cognitive, and motor dysfunction. So depression is depression. We talked about that in that it's got 9 symptoms. It's got a difficulty or changes in sleep, changes in weight. Um, it's suicidal ideation, thoughts of feelings of worthlessness or guilt, um, the psychomotor changes, including retardation or agitation, and so it's all that. Now, um, apathy again has this a few elements that feel like are related to depression. So, in particular, the lack of interest. But this study is building upon past research that says that the symptoms actually do seem to be different. So not only the symptoms, but also the neuroanatomy seems to be different. So the brain regions involved in apathy seem to be different from those that are involved in depression. And a person could be apathetic but not depressed, or they could be depressed and not apathetic. Okay, so what did they find? Well, they found when they distinguished between depression and apathy, that they had these these different components had different effects on recovery, and that they were in fact independent of each other, right? That there was some overlap, but it wasn't heavy. So the other part of this study is looking at self-report versus observer ratings of apathy. And the observer ratings of apathy were what they found is that they were preferable to the self-report measure of apathy. Now, I want to make a caveat that the self-report version of apathy was measured with a single item. Now, in psychology, we don't like to measure things with a single item. You might be familiar with the idea of a scale. A scale is asking multiple questions to understand a single thing. So we have scales of depression, scales of anxiety, and it's best not to use a single item to um, estimate some uh, factor or some trait. It's better to use a scale. The thought process behind it is, okay, a person may not be able to accurately say, oh, I'm a 4 out of 7, or I'm a 5 out of 7. But if you sort of average a bunch of those items together, yeah, you get a better picture of where they fit. Okay, so um, apathy again was related to functional independence measurement during hospitalization. So the level of apathy was related to decreased functional independence, whereas depression was only marginally related. So the p-value wasn't, it was less than 0.10, but it wasn't less than 0.05. Now, I'll just mention that this study, although it's a reasonably sized study, I think that because it was still only 117 participants, I don't feel very confident in it that, oh, okay, if I think about this, should we ignore depression and only focus on apathy? I don't think that this study can conclusively get us there. Don't do that. But for me, what it highlights is that we need to be looking at apathy as a unique construct on top of depression. The other limitation is it did not control for stroke location, which can have a big impact on rates of stroke. So wanted to point that out as well. Now, I want to talk about our second article, which is by Carew et al. This was a recent article. And let me go over the introduction, kind of give you some of the background to the study. So they point out that depression and anxiety are predictors of cardiovascular disease, and that depression is a consequence of cardiovascular disease. So though again, that's the bidirectional nature of depression and the conditions. And then physical exercise, and this is actually broader than just those with cardiovascular disease, but we know physical exercise is associated with decreases in depression. So it's helpful for people who are depressed to engage in exercise. And that's been established not only for the general population, but also those with cardiovascular disease. It's very interesting. We don't know why. We don't know why the exercise is related. There's a bunch of hypotheses, but none of them have been supported to the degree that they seem like they're primary. So it could be that it's just a activity that distracts them from their depressing thoughts. It could be that there's physical aspects to the exercise that are associated with improvements in their mood. It could be, it could be a number of different possibilities. Okay, so the hypothesis of this study is well, they've got two hypotheses. One of them is looking at, different measures of depression and how consistent are they. But the more important for this purpose hypothesis is that rehabilitation will improve the depression score. So they had 28 cardiac patients. They their measurement was an exercise stress test, and it looked at maximal aerobic power, or MAP, and maximal oxygen consumption, or VO2 max. And then they had some measures of depression, BDI, the Beck Depression Inventory, the Hospital Anxiety and Depression Scale, the Center for Epidemiological Studies Depression Scale, or the CESD, and the Geriatric Depression Scale. And then the intervention that they were testing is the rehabilitation program. So this is a pre-post no control group study. And they're looking at the rehab program is an exercise program with educational workshops. Okay, so the most important, well, actually not yet most important. What they found is that the rates of depression varied based on the measure of depression. This is something to be aware of, that the measures we have of depression are imperfect. And so these self-report measures, don't count on them to be precise. Think about them more in the terms of the big picture of who that person is and how they might present. So some of the measures will emphasize physical symptoms more. Some of them will emphasize cognitive symptoms more. Some of them would focus more on the mood or emotion. So that impacts how they might get diagnosed. But the rehabilitation found that there was improved MAPS and VO2, as well as symptoms of depression. So something that's targeting cardiovascular rehabilitation also had positive impacts on depression. And okay, now so that's, I'd say, is the most important for this sake. But I should point out that the study did not find any significant interactions, but this may be due to the low power of the study, given the small sample size, because a sample size of 28, it's interesting for certain circumstances, but I think it's just too small for making conclusive determinations for this kind of study. Now, in particular, this study, and I'm surprised it made it through peer review, talked about differences in the sensitivity of the measures of depression. I really think that was wrong because they should not have done that with such a small sample size. If you're trying to evaluate these different measures, psychology knows how to do this. We know how to evaluate the reliability, validity, convergent validity, divergent validity. So we've got a lot of ways to think about those kind of things. I don't think this is, it's obviously with the different population. All those measures were developed in a general population, not with a rehabilitation setting. But even still, I think that they were kind of out of their league trying to talk about that with such a small sample size. And in particular, they really focus on, well, it could vary from 21% to 50%, but three of the measures, it was really just a difference of one or two participants that really they were looking at. So three of the measures were very close to one another in prevalence. It was the fourth and final one that was 50%. The others were in the 20s. Okay, so I also want to talk with you about the effects of rehabilitation on depression. So that study was an example of it. So cardiac rehabilitation decreased depression among 28 cardiac patients, but let's talk it through the others. So pulmonary rehabilitation, it has been found to confer significant benefits of a moderate magnitude for anxiety symptoms and actually a large magnitude for pulmonary symptoms. So this is with a COPD population, finding that providing them with rehabilitation led to large decreases in their depression scores. And also, I don't have the citation here, but psychosocial interventions to treat depression among those with post-stroke aphasia was shown to be effective for those with mild depression as well as those with no depression. So they found that if you're trying to improve depression, it's not good. It's good for those with mild depression, but it's also good for those who have no depression. So that might seem unusual, but people with no depression could still have some depression symptoms. What they found is that those depression symptoms decreased even among those who were already pretty low on their depression score. So that suggests that maybe we shouldn't only limit this, the psychosocial interventions to help people who have depression. Maybe we should also be providing it across the board. At least that's suggestive of that. All right, now I want to switch gears and I want to take a step back and think about depression and rehab from a few different, actually these are sort of psychological lenses, and see if that can kind of give us some additional insight. So first off, I want to talk about learned helplessness. Now, learned helplessness is a term that was coined by a researcher, Seligman. Seligman did studies where he would, and I apologize, this is actually cruel. So some of you may be dog lovers, and this study was in fact pretty cruel, but it somehow or another made it through the ethics review. And he would place dogs in inescapable cages. So these cages have walls that they can't jump over, and on the ground was a shock pad. And they would shock the dogs at random intervals. And there was basically nothing the dogs could do to be able to escape the shock. So what they found, so again, this is just kind of cruel, but they found that the dogs would just give up trying, right? Because there really is no point in trying. So they learned to be helpless in this situation. And what was interesting to Seligman is that when the opportunity to escape later became available, these dogs would not attempt escape. So they could remove one of the walls so that the dog is now able to, you know, get outside of the cage, and the dog would just simply lie there and not even try to escape. And the this failure to attempt to escape was termed learned helplessness. The state um, just struck Seligman as being very similar to depression. That in depression, a person gives up trying to improve their situation. If you think about it from a cognitive lens, you might say, well, they don't believe that anything that they can do would help their situation. Of course, these are dogs, so they're not thinking in that sense, but they're basically in a situation where they give up on trying to help themselves. And what was remarkable is that even if they sat outside the cage and said, "Come here, come here, come here, boy, come here, girl," they couldn't coax the dog out. They would even offer treats and say, "Okay, here's a treat," but they wouldn't like put it right in front of their face. They would hold it over there. The dogs would still not come. It really was a pathetic state that they were in. The only way that dogs would learn to escape was if they were physically kind of carried out of the cage and then, put back in. So if they had the experience of being taken out of the cage, that's when they, you know, when placed back in, would actually realize, oh, there's an escape, there's a way out of this. And only after physically being removed from the situation would they actually be able to perceive, oh, there can be some help here. So theoretical developments have found that hopelessness and pessimism contribute to depression. So basically, theory kind of recognized that people aren't dogs. So it's we have a capacity to think, and they found that our thinking, if it's hopeless and if it's pessimistic, can lead to this state of learned helplessness, which is again very close to depression. Now, I point all this out because in a rehabilitation setting, a person who is experiencing the inability to move their arms or the ability to speak, or they might be lying in a hospital bed, they might very well experience that as a state of helplessness. And even if they experience that for long enough, even if they might have things that they can do, it may not be easy for them to get themselves going. And again, I think our culture sometimes gives us messages about depression that says, "Oh, you shouldn't enable them. You shouldn't just sort of you should make them work at it themselves, right? You could tell them what to do, but they need to do it themselves." Now, learned helplessness kind of pushes me against that. Sorry, learned helplessness pushes it against that idea a bit because it suggests that actually, when a person's in this state, they can't be coaxed or persuaded out of it. They actually have to be helped to be able to overcome it. And again, just like the dog, sometimes we might have to physically kind of help a person engage in rehabilitation exercises and try to decrease the work that they would have to do to become involved in it, so that they can discover that, wow, there's actually something I can do to get better. So I think that's an important thing for all of you studying in this program to think about, because I think sometimes, again, we think we just need to persuade them and talk them into it, but sometimes it might actually be a little bit more, physical and really lessening that gap between the well, maybe it's the hospital bed and um, the room where they'd be doing the rehabilitation exercises. So whatever you can do to decrease that work would be best. Okay, so that's one thought. Another theoretical framework that I think might be helpful is interpersonal therapy. So interpersonal therapy was developed to kind of explain depression. And instead of prioritizing um, the way that we think that cognitive therapy would sort of emphasize, cognitive therapy would sort of emphasize that, oh, the way you perceive your situation is the cause of your depression. Well, instead of that, the interpersonal therapy says, well, we're primarily relational creatures. And so we need to think about depression from a relational, interpersonal context. And IPT, interpersonal therapy, argues that depression could be caused by one or more of four different um, social interpersonal factors. So one of those is role transition, transitioning from one role to another. Now, for this theory, it might be transitioning from uh, being living in your home with your parents to living by yourself at college, or it might be transitioning from one job to another job. Just all of it, or maybe it's transitioning from, taking care of your kids to being an empty nester, or being an empty nester to taking care of your parents. So that could be one factor that can cause depression. Another is role conflict. So when two or more people disagree on what's my role, what's your role. So that happens with kids and their parents. It can happen with couples. If there's a role conflict, that can lead to depression. The third is a lack of social skills. So if a person is lacking in social skills, they're not able to really connect with other people. That can cause depression. And then finally, grief or bereavement could be a cause of depression. And when I think about this in regards to the rehabilitation context, certainly the well, the injury and the disease could have implications for our interpersonal role, but it can also the uh, the rehabilitation context itself can have contributions to depression. So one aspect is being in the sick role. So the transition from perhaps being a successful and productive worker, or just having a role to play, to being in this role of being sick could be a difficult interpersonal transition. It's a transition to a very new role that the person may not be familiar with. And as a result, that transition could cause them to feel depressed. And partly that could be because of the guilt or the feelings of burdening others that could go along with being in the sick role. So that could be a cause of depression. Another cause could be that there's a conflict over, being a patient and taking directions. It's difficult. This is kind of related to the last one, but it's difficult to be a patient because your life is no longer dictated by yourself, and you now have to be told when to do things, and you don't get much choice. Um, and so that could be a factor. Then you have impairment of social skills, and I think about this with, let's say stroke. If a person has aphasia, they're going to be less able to communicate, to maybe to joke. They might have a little bit more slowness, and so they might not be able to react as quickly to others around them, and that can lead them to feel depressed. And then finally, just the loss of independence and functional capacity. So there's an element of grief, not not that not the loss of someone dying, but the grief of losing your capacities and your independence. So the person is grieving, and that could lead them to feel depressed. So certainly those are things to keep in mind, and be attentive to when you're in the rehabilitation context. Okay, now lastly, I want to talk about suicidality, and I think that's an important thing to consider. And let me give you a little bit of the epidemiology of suicide. So suicide attempts are most common in people between 18 to 25 years old. But suicide deaths are actually most common among whites and Native Americans, as opposed to Blacks and Asian Americans and Hispanics. So they're almost, not quite, but almost twice as prevalent among whites and Native Americans as the Blacks, Asian Americans, and Hispanic Latinos. But also among the middle-aged and the elderly. So oftentimes people think that suicide rates are highest among the youth. Well, suicide attempts are highest among the youth, but they're actually quite low among younger populations, that they would actually die by suicide. And so there's sort of a bump at about 50 to 60, and then there's a sort of a valley, and then over the age of 85, you see another increase in the rates. And so certainly when you are in the rehabilitation context, you might be seeing people, again, around these ages. Older adults are probably more common. And so that's something to be aware of. Also be aware that women are 2 to 3 times more likely to attempt suicide. Although men are it's about 3.5 to 4 times more likely to die by suicide. Okay, so suicide attempt survivors, how is suicide connected to rehabilitation? Well, one way is that suicide attempt survivors may be admitted for rehabilitation. We know that, firearm deaths are very lethal. However, about 10% will survive. Then overdose could lead to hypoxia, could lead to a variety of physical, liver damage or kidney damage, and that could lead to rehabilitation stay. And we know that suicide attempt survivors often have problem-solving deficiencies beyond those associated with depression. So just kind of keep that in mind, that depression will have some problem-solving deficiencies, although suicide attempt survivors might be particularly liable to that, right? Because suicide is an attempt to solve a problem. It's obviously a maladaptive attempt, and that reflects these general problem-solving deficiencies that this group tends to have. Also, just kind of be aware that the individuals with diagnoses commonly associated with risk of suicide include cerebral vascular accidents, amyotrophic lateral sclerosis, epilepsy, and Huntington's disease, multiple sclerosis, Parkinson's disease, spinal cord injury, and traumatic brain injury. So certainly be aware of that increased risk. Another study found that suicidality is associated with TBI, and in an interview study of TBI survivors with a mean of 8 years post-injury, they found that there were 6 main themes that were identified that were related to their thoughts of suicide, and that included loss of sense of self, feeling like they're no longer themselves. TBI is a hidden disability, chronic but transient suicidality, so that they chronically feel suicidal, but not all the time, right? It's transient, so it's over a long period of time, but it's not every moment of their life that they feel this way. Reliance, relying on others was a big theme. Protective factors, that there were some protective factors, and then hope was an important theme. So the protective factors were social support, so having the support of their family and their friends, spirituality, so faith and spirituality and religion, and then finally positive personal characteristics, their humor, their adaptability, their toughness, their grit, things like that. Lastly, just want to explain that when you're trying to assess for suicidality, it's important to think broader than just asking them about suicide. It's important to ask them about suicide, but don't only ask them about suicide. And what do I mean? Well, if they there's a something called a suicidal crisis, and the suicidal crisis syndrome has been found to be related to imminent suicidal behavior. So if a person is in a suicidal crisis, they are liable to attempt suicide in the near future. And what this entails is an experience of feeling entrapped. So if you see yourself as trapped, and if you feel emotionally flooded, you have cognitive rumination, so you get stuck on a certain way of thinking, and then behavioral agitation, which can include, again, the agitation, the fidgetiness and restlessness, or insomnia. Again, these are the aspects of a suicidal crisis, which is associated with imminent risk of suicide. And the key thing to know is that the person may or may not report suicidal ideation. That's what the SI stands. Sorry. So the suicidal crisis is important to assess, not just based on self-report, but also carefully observing them. So observing, do they seem to feel like they're trapped? Do they talk about feeling trapped or kind of in a cage? Do they talk about just their emotions running all over the place? Do they seem to get stuck on a certain way of thinking? And do they get easily agitated? If so, even if that person doesn't, even if they deny suicidal ideation, it'd be important to refer them for a psych eval. Okay, so hopefully that was helpful in kind of unpacking this relationship between depression and rehabilitation. I hope you enjoyed it. I enjoyed putting this together for you. So I look forward to chatting about this further when we get together for our meeting. So yeah, look forward to doing that. All right, take care.